Okay, so I'll be talking about HFrEF management beyond guideline-directed medical therapy, which of course we know is critical in the management of all our HFrEF patients, but I'll be concentrating on devices, which is a very exciting field of development, but it's quite different to drug treatment, so I'd like to go through that. Here are my declarations down the bottom of the slide. So first of all, we have very many treatments that have crossed the major threshold of reducing mortality and morbidity. We look at these and we see the first positive trials were in the 1980s. Now, I was a medical student in Cambridge in the early 1980s, and we were told that there was no point telling patients they had heart failure because there was no effective treatment. But that was just when we started developing these treatments. So we see the ACE inhibitors, the beta blockers, mineralocorticoid receptor antagonists, angiotensin receptor blockers, ARNIs, and then SGLT2 inhibitors, as well as other drug classes such as ivabradine, vericiguat, omecamtiv mecarbil, intravenous iron, and some non-pharmacological treatments such as exercise training, inflatable monitors, and even surgical techniques have improved the outcomes. So we've gone from an area where nothing worked to an area where we have multiple treatments that are available for our patients. And as a result of that, we've got a much more complex way of managing it. But there's no point having these treatments unless we really implement them. And when we're managing individual patients, we need to get the standard therapy and then look at the individual subject and see what else we can do to improve on that. I'm concentrating today on the things beyond the foundational 4 drug classes, which of course are the RAS inhibitors, ACE-ARB or ARNI preferred, MRAs, beta blockers, and SGLT2 inhibitors, to what you can do after that to the patient who remains symptomatic, and I'll be concentrating on devices. So the ESC guidelines in 2021 had a significant focus on devices. And if we look down at the bottom of this panel, most people concentrate on the top, which is the 4 foundational drug classes, ACE, ARNI, beta blockers, MRAs, and SGLT2 inhibitor. But then down the bottom, there are treatments you can give for patients in certain circumstances, such as sinus rhythm with a prolonged left bundle branch block, QRS, CRT, pacing or defibrillator, ICD for those with ischemic etiology, and there are other treatments that you could suggest that include devices. When we look at what's happening in devices in the 2021 guidelines, we see a minor change to the ICD recommendation because of a trial called the Danish study that suggested that it couldn't prove there was a benefit on mortality of an ICD in patients with non-ischemic cardiomyopathy. Probably that was because the effective drug treatments have reduced the risk of cardiac mortality in these patients quite substantially. So we still had an indication for ischemic HFrEF, but not for non-ischemic. And here's with the Danish trial. Now, you could say that that showed that the ICD wasn't beneficial in non-ischemic cardiomyopathy in terms of all-cause mortality. But if you look at the event rates over 8 years, we're getting a cumulative event rate under 4%. So basically, in terms of all-cause mortality, these patients had extremely good outlooks, and the trial simply wasn't big enough to show a significant effect. If you look at sudden cardiac death, it was significant, but that was a minority of the endpoints for these patients. Because quite simply, we now restrict ICDs and non-ischemic cardiomyopathy to patients where we think the risk of arrhythmic cardiac death is substantial. Where the risk is very small, it may not be necessary. What else has changed? Well, there was a change to the CRT recommendation, and that's because we had some improvements in our knowledge about the appropriate patients. In 2021 guidelines, we're now getting a class 2A recommendation for QRS durations between 130 and 149 with left bundle branch mortality, because it was felt looking at the results weren't that convincing unless you had a QRS greater than 150. There was an increase in the recommendation. However, if you had patients with left ventricular ejection fraction below 35%, if they had a conventional pacemaker or an ICD, and subsequently developed worsening heart failure despite optimal medical therapy, where they have a significant proportion of RV pacing, those patients should be considered for an upgrade to CRT. One of the important ones was the ECHO CRT trial, and that looked at patients with QRS durations up to 130 milliseconds. And what it actually found was an adverse outcome of using a CRT in these patients. So there was clear differentiation between with a very prolonged QRS duration, greater than 150, where CRT was indicated to reduce mortality, and when QRS is less than 130, it actually had an adverse outcome. So we had a better resolution of what we needed to do, and in terms of better accuracy in patient profiling. When we look now back at the strategic phenotype overview of the management of HFrEF, and we look at these devices, there are other devices down there later in the table, such as the treatment of aortic stenosis with TAVI, transcutaneous aortic valve implantation. We have a softer recommendation for epithelial for leaflet repair, mitral valve, particularly the MitraClip device. And of course, we have mechanical circulatory support for bridge to transplantation or bridge to recovery, and long-term mechanical support or destination therapy for mechanical circulatory support. But once we look back at managing the patients, we first of all now all strive to get the decent doses of the 4 foundational drug classes, because that we know will improve quality of life. It will reduce the risk of heart failure hospitalizations, reduce mortality. But the patients are still a far way from feeling well. If you look at patients with class 1 to 4 heart failure, you see the quality of life shows a progressive reduction in the KCCQ score, and we see a increasing severity of symptom disability in these patients. The rate of 1-year hospitalization goes up with that symptom class, so it is a marker of a patient at high risk. But what can we do for these patients when they've already taken all the treatments they can from the foundational 4 drug classes? So we look back at devices, and yes, we now have an indication for aortic valve intervention, TAVI, or surgical aortic valve replacement with severe high-grade aortic stenosis, and how to choose that. We have a recommendation for percutaneous edge-to-edge mitral valve repair, but that's in carefully selected patients with secondary mitral regurgitation. They're not eligible for surgery and needing coronary revascularization. But the interesting one was repair, transcutaneous repair, to improve symptoms in carefully selected patients who are highly symptomatic with moderate to severe mitral regurgitation. We also have, of course, we always have the devices that are mechanical circulatory support as a bridge to decision, bridge to transplantation, and that will be a minority of patients purely because of the complexity and cost of having a mechanical circulatory device program. It will remain a minority for the available patients who could reserve. But I now turn to mitral regurgitation, because that's something that's exploded over the last 5 to 10 years. We know that you can get primary mitral regurgitation as a cause of heart failure, but we also have increasing interest in secondary mitral regurgitation, where we believe alterations in the valve leaflet, but also in the myocardial volume and remodeling, cause a remodeling of the heart, can dilate the leaflet tethering, and you get functional or secondary mitral regurgitation, can then make ventricular remodeling worse and can contribute to symptomatic severity. There are multiple devices that have been developed over the last 12 to 15 years. The first was the MitraClip you show here, which a device that can be put in, inserted transcutaneously, clip the 2 leaflets, bring them together so the total amount of regurgitation is reduced. Then we have a simpler device called the Carillion device that is implanted around the coronary sinus, and it's passed through there and then shrinks the diameter of the mitral valve orifice so that you get a reduction by simply reducing the total thing. And there are newer devices such as Mitraline, as shown here. What we had, coming back now a few years ago, we had 2 interesting studies coming out around about the same time. We had the MITRA-FR study from France, not huge numbers, but 300 patients or so, that showed no benefit of using MitraClip. But we had at around about the same time the COAP study of slightly more patients, 600 patients now, with a substantial reduction, a 37% reduction in the composite primary outcome, showing superiority of MitraClip over guideline-directed medical therapy. There was a lot of debate and uncertainty about the reason for those differences. Was it the trial experience? Was it the larger numbers? Or were the patients subtly different? And we believe probably it's the last explanation. Now, we will get further information literally in the next few weeks with the results of Reshape HF2, which is a very large study also looking at MitraClip that's somewhat between these two trials. So we'll get further resolution on the patients who really respond to the treatment of secondary mitral regurgitation. We did a recommendation paper on the management of secondary mitral regurgitation, and it's highly complicated. What you require is you need, first of all, to see whether people need revascularization, because that offers a surgical option. If they don't, then the option is to look for transcatheter thing. It requires detailed echocardiographic evaluation of clinical criteria to see whether they satisfy the group who were recruited into COAP, because they were the group who showed the criteria that would benefit. And if they satisfy the COAP criteria, you should consider percutaneous edge-to-edge mitral valve repair. Now, another treatment that's, I think, of considerable interest is a device called cardiac contractility modulation. And in a way, it's a bit like a pacemaker, a bit like a CRT, but different. What it is an implantable device that stimulates the myocardium. You see repetitive stimulation, but it's delivered close to the action potential. So it's not designed to activate the myocardium. It's designed to electrically energize the myocardium. And it's a well-known physiological principle that when you stimulate the myocardium during the action potential, you can enhance contractile force. Biological effects are seen locally, but they actually spread more remotely over time. So you see gene alterations with repetitive stimulation of the myocardium, not to produce a contraction, but to change contractility. And it's delivered with a very pacemaker-like device with two right ventricular septal lead and an atrial lead. Shown here, you see with isolated ventricular trabeculae that when you stimulate during the action potential, you increase the developed force of myocardial trabecular contraction. And that's been shown in isolated myocytes, in myocyte preparations, but also in whole hearts and in the whole intact human heart organ. We did an individual patient data meta-analysis of all the randomized trials of this CCM device in patients with HFrEF. And what we showed is significant improvement in peak VO2, the best measure of objective cardiopulmonary exercise tolerance, an improvement in a 6-minute corridor walk test, and an improvement in quality of life, here measured by the Minnesota Living with Heart Failure score. So it may be an option for patients who remain very symptomatic. It's not the same as CRT. It's for completely different patients. It's designed for people with narrow QRS duration who are not eligible for CRT. And it's something that you can offer to selected patients to improve exercise tolerance. That was subject to an FDA-approved confirmatory study called the FIX-HF2. It was given expedited access pathway designation by the Food and Drugs Administration for priority review. And in this, 160 patients were randomized 1-to-1, US and Europe, ejection fractions between 25 and 45%. So not classical HFrEF, but actually a composite between HFrEF and HFmrEF, because it was found in the earlier studies that very poor left ventricular function didn't respond so well, but there was actually improvement in patients with a more mild systolic reduction. So it's interesting, it's the first treatment with an approval now for a different range of ejection fractions than the classic HFrEF or HEMrEF. The primary efficacy endpoint was an improvement in peak VO2, the best measure of exercise tolerance, and there was a primary safety outcome endpoint. What it showed, and this was a Bayesian analysis, so it borrowed for some power from the previous studies, there was a statistically significant difference of 0.84 mils per oxygen uptake per kilogram per minute, which is quite a useful improvement in exercise tolerance. And associated that was a change in Minnesota Living with Heart Failure questionnaire that was highly significant, and an improvement in the chances of improving one New York Heart Association class. Then another group of devices are very fascinating for those of you who study the pathophysiology of heart failure. And that is, there are major abnormalities of autonomic balance, sympathovagal imbalance, and reflex changes. And we can now do a lot more with what's called electrotherapeutics, stimulation of the autonomic nervous system to alter the balance of the sympathetic and vagus. We can try vagal stimulation, we can try spinal stimulation, which can inhibit sympathetic outflow, directly stimulate the baroreceptors in the neck region, or we can denervate the renal arteries that reduce the local sympathetics to the kidney. And all of those have had their proponents. They've all had modest-sized trials, and some of them have showed some potential, but we really hadn't had a very powerful study until fairly recently. The early modulation trials were negative. Vagal stimulation, the Nectar-HF, tiny numbers, no significant change in left ventricular volumes. Spinal cord stimulation, also very small numbers, 66 patients. Also a left ventricular size endpoint, not significant. Baroreflex stimulation, that was the device, the barostim, that stimulates the nerve fibers within the carotid baroreflex. That was 146 subjects, and that did improve exercise tolerance, 6-minute corridor walk test, and quality of life, and reduced N-terminal proBNP. So that probably had the best candidate phase 2 results. Vagal stimulation, a larger study, did not show a benefit. So the one that seemed to have passed the first threshold was baroreflex stimulation. The mechanism of that is that if you stimulate the carotid sinus, you can lead to sympathetic inhibition and vagal increase, which is known to be associated with better cardiovascular physiology. That leads to a reduction in heart rate, a reduction in left ventricular adverse remodeling, a gentle vasodilatation, a reduction in blood pressure, and an increase in renal responsiveness in terms of diuresis and inhibiting renal secretion. So it had the sort of ancillary benefits that would be beneficial if we could achieve them reliably and sustainably in HFrEF patients. So this underwent 3 trials. Phase 1, which was an early mechanism of action study of only 11 patients. Phase 2, HFrEF, I've shown you 146, and then a pivotal BEAT-HF study that was also subject to the FDA breakthrough device designation, a 408-patient trial that looked both at functional endpoints early on, which could lead to approval, with a later requirement to evaluate the effects on mortality and morbidity after approval had been achieved. What we saw with BAT is we do see a significant reduction in sympathetic activity. We do see a sustainable and increasing vagal activity, which are all benefits we'd like to see. And in the pivotal study, which was designed to look at safety and effectiveness, this was randomized 1-to-1 to receive baroreflex activation therapy on top of optimal medical therapy in class 3 patients with ejection fractions below 35%, limited exercise tolerance, 6-minute corridor walk test between 150 400 meters, elevated N-terminal proBNP or previous heart failure hospitalization on the background of stable medical therapy, excluding patients who were eligible for CRT and hadn't received it. What we saw was a significant increase in exercise capacity measured by 6-minute corridor walk test, a significant improvement in quality of life measured by Minnesota Living with Heart Failure questionnaire, and a significant reduction in N-terminal proBNP, showing that these had the hallmarks of useful beneficial effects. Another autonomic system, which we wouldn't really think of, but I think is actually modifying the autonomic system, is a system designed for the treatment of sleep apnea. But in this case, central sleep apnea, which as many of you will know, is rather like Cheyne-Stokes respiration. It's an abnormality particularly prominent in chronic heart failure, and it leads to a cyclical overbreathing and underbreathing that is associated with worse outcomes and increased risk of mortality. The patients get very poor sleep quality. So this company, Respicardia, now part of the Zoll group, developed an implantable device that stimulated the diaphragm, shown here, and it could take oscillating breathing, central sleep apnea as shown in this graph, and when the device switched on, you get regularization of diaphragmatic movement and sleep pattern goes back to normal. So they did a pivotal study, and here looking now at the group of patients with heart failure in the pivotal study using a stimulatory device of the diaphragm to treat sleep apnea, what we saw is a highly significant improvement in sleep metrics, a highly significant improvement in the quality of life, particularly the abnormalities associated with sleep apnea, and a significant patient preference for being treated this way. patient global assessment you see had a dramatic increase in the patients who presented themselves improved compared to reduced. And that was associated with a numerical reduction in the risk of heart failure hospitalization, but it wasn't big enough to prove it changed major outcomes, but it definitely improved quality of life in patients with heart failure who had coincident central sleep apnea, which is probably about 35 to 40% of the HFrEF population. Lastly, another device that's underdeveloped, devices that could decompress the left atrium, septal devices. There are a couple of different manufacturers there. The principle is to put in a controlled hole between the left and the right atrium. Here are a couple of devices shown there that will allow graded and controlled decompression of the left atrium that can relieve the risk of pulmonary edema and possibly improve the hemodynamics of these subjects. This has been subject to a couple of trials, but the results have been somewhat confusing. In one, HFpEF patients seem to benefit more than HFrEF. In the other one, HFrEF patients seem to benefit more than HFpEF. And it seems the results depend on the precise levels of pulmonary artery pressure. There's probably a point of pulmonary vascular resistance increase where these devices are no longer helpful and could be harmful. So I think we will see more of these devices, but the jury is still out on the exact selection of patients. So in summary, beyond guideline-directed medical therapy, we now have multiple devices that have been well established in heart failure. I think they have not displaced drug treatment and probably never will, but they do offer something for our patients who remain limited. Decreases in all-cause mortality by developing ever more drugs will become less and less likely, but the heart failure patients saved by these foundational 4 therapies will continue to deteriorate and suffer poor quality of life with impaired functional capacity. And this cohort of patients have increasing needs. They will drive ever more innovation with implantable devices because we're getting so much better at miniaturization, good power schemes, and more exciting ways of intervening, either autonomically, hemodynamically, or by monitoring. Unlike drugs, devices are not primarily aimed at reducing mortality, although some, such as CRD and ICD, can do it, but the predominant use is to improve quality of life in these patients, keep them stable. We need to assess safety and patient benefit, but we should not be obsessed with doing trials so large they always seek to reduce mortality, because that is going to be a very difficult endpoint in the future. And we require novel approaches to the complex pathophysiology of heart failure and treating common comorbidities, such as sleep apnea I mentioned, and also other things like iron deficiency. And new treatments will continue to emerge, and the future of a heart failure physician is very exciting because of so much more we can do from our patients. I'd like to stop there, but really would value interaction with any questions and answers. Thank you very much.